This video is a proprietary commentary for the therapeutic value of prescribing CPIN protocols, which includes utilizing Correct System theory and device as the primary home-based method for treating common musculoskeletal diagnosis. The aim of this video is to explore and explain the reasoning for the CPIN protocols to our clinical colleagues with this informal and lively presentation. And welcome back. My name is Dr. Dean, and I'm here with
Venzel.
And today we're going to follow up with part B of the Y Core X system. So in part A, we talked a lot about sort of the upper level sort of rationale why physiotherapists or clinicians or athletic trainers or occupational trainers or even like CSCS, anybody athletically inclined. And we also included regular folks, right?
Yep.
So what's the appeal Y Core X system? So this is the second part, and we're going to be sort of digging in a little bit deeper. So I just want to recap quickly what we're kind of up against. So our appeal is to get you to consider our platform, our therapy approach, maybe over the classic PT program. So in the classic PT program, the rehab, generally what's covered by insurance is to manage pain
management, yeah.
Right, reduce pain, and then also to restore what we could say like pre-injury status, right?
Yeah.
So we would be rehabbing for active range of motion, maybe some strength,
Yeah.
right? So the insurance model pretty much covers reducing pain, right? Like palliative care.
Yeah.
In our opinion, that could be done at home with some instruction. You don't need to drive to go someplace and be
15, 20 miles to go
Right.
to an appointment and sit in the lobby for part of it.
right for
Yeah.
ice and heat.
Yeah.
Right. You could do that at home. So yes, palliative care matters, but we're saying that could be done at home.
Yeah.
So what we're looking at again is the palliative part, the restoration to pre-injury status, which is by and large determined by the patient,
Yep.
right? So if they say, yeah, well, I used to be able to do squats with a 10-pound bar, right? That's all that they would get, right? So what we're offering is like, honestly, like the whole body rehab.
Yeah. And then too, with they could have, like what we talked about in the last video, they could have had a mechanopathology that limited their range of motion in the first place that led up to that injury. So it could have been an improper or faulty movement pattern from the get-go that they felt strong, but it was detrimental. And then in therapy, you're looking at, dealing with, measuring it against the other side. So if it's on the left side, you're comparing it to the right, and that's the rehab component. So getting back to that, you just want to kind of mirror the other side and not so much increase both the range of motion and the mobility as well.
Right, and you just brought up something really important that I've never thought about before is maybe they're restoring them into the faulty motor pattern.
That's it. Yeah.
And it hasn't been identified, right? So then there's that, and then so you're looking at a re-exacerbation.
Exactly.
Right? So basically, and then like Venzel just said, that the rehab is going to be at the knee.
Yep.
It isn't going to be necessarily, the knee as a pair, right? We kind of call that like the dynamic duo. If you rehab one knee, you kind of have to take them along in the therapy together. Don't leave one guy out.
Yeah.
Right? We'll talk about that in a minute. So the therapy is going to happen at the knee. It's going to have a palliative, a strength component, and it's going to restore, like we said, potentially, hopefully not, but restore them into a faulty motor pattern that hasn't been identified yet. Okay, so the opposite of that, or let's not say opposite. Let me change that. Let's say an alternative, right?
Yeah.
That's out there, that's conservative care. It's not conventional, right? But I mean, I've been doing it for 15 years and just seen amazing things happen. So this isn't going to be like, just follow along. This isn't going to be like the classical PT model, okay? Yeah. This is way more expanded, and I would say even more inclusive. So the first question we could ask on the Correct System therapy approach is,
what we would ask most likely is, why CoreX?
Right. So because it's more universal, right? And so if I'm going to start a therapy, I would say, well, what does the knee do? Right? It does have a strength component. There's that. And maybe with a patient that has a pain issue, but one job that the knee does is not to produce pain. So why are we addressing the pain?
Gotcha.
Right?
Yeah.
So in a therapy platform, an all-inclusive platform, we need to really understand all of the things that the knee does. Okay? And that becomes the therapy. Right? So one thing that the knee does is it's a hinge. Right? But if the therapy ends with that, you're missing 90% of what the knee does.
Yeah.
Right? So we're going to explore that a little bit. Okay? So first thing in CoreX system therapy approach is to understand, in this case we're going to be using the knee, so we can kind of keep it simple, is to understand what that joint or that group or that sling, what's going on with the injury, right? What is its job? And then we're just going to restore the job, okay? All right, and then what we're looking for is the fastest way to achieve goals.
Yeah.
So we're looking at restoration of RTP, sometimes in one day, the same day,
Yeah.
right? And then ADLs or activities of daily living, right?
Yep.
For our usual, maybe some non-athletic or mildly athletic patients, right?
Yeah, in the occupational field.
Yes,
Yeah.
like at work even.
Yep.
Right, okay, good. And so another benefit of this is it has high accessibility, right? And that's a long laundry list.
Yep.
So no going to the appointment, no driving.
And literally, you don't have to spend any money traveling, or the only thing you probably need is just internet,
Right.
have your internet, computer, and
Or your phone.
Oh yeah, or your phone.
Right.
And literally, a lot of the content is it's free, so take advantage of it.
Right. And so there's no getting a babysitter, there's no sitting in
Yep.
traffic, all that stuff being, waiting.
Wasting time. Yeah.
You said even before, like sitting in the lobby.
Yeah, the
Right.
lobby.
All of that. You can think of anything negative about going to a doctor's appointment. We eliminated all of that,
Yeah.
right? So it's high accessibility, and then of course it's at low cost.
Yep.
And then what we're hoping for is the highest quality patient experience and satisfaction.
Yeah.
Right? So it isn't like in PT, classical PT, they're delivering services, but it isn't, one of the measured outcomes isn't their satisfaction,
Yeah.
or did they have an amazing experience with their therapy? Not just the results, but with the therapy process itself, right?
The psychological component to it, because that matters. Like we talked about with pain, having psychosocial, effects, and the perception of it. So if we don't, gauge our patient psychology through their rehab, then like we're doing a disservice to our clients, because you have to pay attention to how they are adhering to the program, as well as how they feel in the program. So that's very key to have a successful program. Because if you don't incorporate that component, the mental as well as the physical, then obviously you can probably get their range of motion back, but then will they adhere to what you have showed them?
Right, so that makes me think of, will they respect the therapy
Yeah.
and maybe continue it on their own, or understand the value
Yep.
of it, right?
Yep.
So, and then that's a component that we're hoping to deliver,
Exactly.
5 stars across the board. Okay, so let's kind of break it down, and let's start with, what does the knee do, okay? So number one, most thing,
Yeah, bends in the sagittal plane,
bends in the sagittal plane, right? And then it has a little bit of
torsion,
minor rotation,
yeah.
right, on the meniscus, but very small, right, to a point, right? And then it also accepts loads via ground force reaction, or GFR, right? So what we're talking about, let's do a demo here.
Okay.
So one thing that the knee is going to do is even if I just gently step on the floor, it's still accountable for delivering the stability of the floor through my ankle, right through the knee to the hip, right? So the knee is relying a lot on the ankle. If the ankle isn't stable, the knee can't do its job, right? So let's show the folks an example of like that quickness of the, just turn here a little bit, of the post, right?
Okay.
So that it's sort of like, so we say sometimes like if you're just coming up, right, that's that pillar. Now I'm not hyperextended, I'm locked in the pillar, right? I'm transmitting load, but there's a little more stability and balance. What we're talking about in this post is driving down into the ground, right? So, and your track star, right? So what does that look like?
So from the pillar to the post, it looks exactly like this. So nice and controlled. Nice and controlled.
And so, yeah, keep going, Benzel. So you can notice there's a quickness from that high, like that figure 4, down, or that flamingo stance down, right, into the ground, and then stabilizing, right? So the knee is absorbing load, and it's transmitting it through the ground force reaction up into the hip, and essentially giving information to the core to simultaneously lock in, right? Yeah. Okay, so that's good. All right, so that's just an example, kind of expanding that the knee doesn't just,
bend,
right? And so what we want to mention is that in the correct system is that all of the therapy is standing. So if I sit on a bench and you're the therapist and you say, bend your knee, I'm not experiencing any ground force reaction. It's all very passive, right? And there's no quickness, there's no suddenness, and there's no responsiveness to ground force reaction. And that's extremely important, right? So we're going to be rehabbing that knee, adding those features, okay? And we're not going to be doing it one exercise at a time, right? So, and which is also in classical PT is, there's a handout, and first we're going to do this and this and this and this and this and this and this, right? All these individualized things, but the problem is they aren't sort of, I'm just going to say like critically connected through the core, or to ground force reaction, or to suddenness or quickness or acceleration into deceleration, which is all about either athletics being successful
or your
regular
ADLs.
folks getting injured,
Yep.
right? Okay, so accepting loads, and then also we talked about transmitting loads. So there are those three planes of motion, which are
load. Planes of motion. You got sagittal, you got frontal, and then you have the transverse.
Right.
Yeah.
Okay. So those three planes of motion can be understood at the knee, even though it's primarily sagittal. Right. There is, well, we just said it. Right. There's an axial, or what we call load in correct. So I'm putting my heel down. Right? So load, right? I'm locking into the ground. So the force is coming through the long line of the bone. So we can understand that also as a sort of a plane of motion, right? And then there's rotation, or what we call torsion. And you said transverse, right? It's basically the same thing. So torsion of the knee is basically this element, right? Now I'm twisting primarily from the ankle, but my knee is uptaking that rotation. Okay, and then so the biggest example that we could show, which would be obviously rehabbed absolutely for sure in a knee program, is that varus valgus, right? Sort of like, I don't want to call it so much a deformity, right?
It's a faulty movement pattern though.
It's a faulty movement pattern, right? So let's say I'm going to turn, right? So I'm just coming down the line, and I want to turn, and I'm going to step to turn, and I turn my hip and I turn my knee, and the knee follows the hip. That's not stable. That's torsion, but it's not functional torsion, right? And that's an injury because I'm standing and doing my rehab and not sitting, because I'm standing when I turn and I turn my hip and the knee follows, that becomes a new faulty movement pattern on top of the one that hasn't even been diagnosed, right?
That's how you tear the meniscus.
Exactly, right? So we were talking about this a little bit before, kind of get prepared.
Yeah.
And so the COREX therapy approach is the whole patient, the whole body, the whole athlete approach, right?
Yeah.
So what I need to do is I need to understand that when I turn, which is a function of the whole body except the knee, like I need to turn the whole body, right? So that's an action where the whole body is doing something, the knee needs to participate. So when I turn, I actually need to push that knee away. I need to push the knee away to be stable in that movement, right? So we take a faulty movement pattern and make it not faulty, make it a true motor pattern. So that's an example. So can you just show that rotational part, like a quick turn, like if you were just running down the line and you were going to dart over to the left, and how that knee goes out to the other side. So like a little real-time thing. Like you can kind of stammer step like this, and then just like you're going to do a quick turn. Right, good. So if you look at his knee is pressed out, right? That's awesome. I love that. You're so fast.
See, look, I had to control myself because I wanted to go that as soon as I got it. And then the good thing is, when I was in that position too, if I needed to, all I have to do is push out and I can change directions.
Right.
That's literally, so I didn't feel like I committed too much to that one side. So if I need to make a sudden change, all I had to do was externally rotate this femur.
Right.
Bop, and then I can change directions.
Yeah. And so, without giving too much detail and going, down a
rabbit hole,
the knee path, because that's just how we are.
Yeah.
We're just like get a thought, and we're just like, oh, let's go here, let's think of this, whatever. Anyway. So the idea is that the COREX therapy approach is going to include things like that, right? Those whole body movements. It isn't just a therapy of the knee, it's the knee included into the whole body unit, right? So then we talk about also before transmitting load to the hip, right? So anything I do, even if I just step out here to the side, I'm transmitting a load to my hip. The knee is not acting on its own, right? Yes, you can use the knee like in a lunge or something, sort of a functional range of motion, active range of motion. But the truth is the knee does so many more things than just that, right? And almost never has a job absent of ground force reaction, just lifting up and down, sitting in a chair or on a treatment table. And then like we said before in the beginning, that they're kind of the dynamic duo, right?
Yeah.
So like what you were saying is like if I turn here, the knees have to turn here. If I turn here, the knees are going to follow, right? They act as a pair, right? And then they make the world's most amazing tripod, right? Which also is transmitting load to the hip, and then just by obvious reference to the core, right? So the core is reading those forces coming through the legs, either unilaterally, bilaterally, right? And then the quality of it, is it more of a through the heel, or is it more of a
post,
through the toe, with that softness still happening in the heel, right? So those are two completely different transmissions that the knee needs to understand, right?
Like for example, with the spine, like a sprinter versus a jumper, the load will be more on the heel for a jumper, and then for a sprinter, it's on the ball of their feet. So just that transmission alone, your spine has to be in a slightly different position, just from that alone. So you have to get your core recruits slightly different between those two movements.
I totally agree. So we're making some reference into athletics because that's mostly what our interest is. So the knee kind of also can produce power, right? And they say, well, how? Like, I would say like through a kick, right? But then, can you grab a volleyball? But then, this is kind of oversighted in PT. Go ahead and stand up, face the folks there. And then, yeah, face that way.
Okay.
And then just come a little wide into that core neutral position, right? So he doesn't have the device on, but I just want to give an example. So that's a load to the knee, right?
Yep.
So that's stability. And as soon as I do this, he's automatically cueing his core, right? So this is a knee drill, right? This is knee stability, right? There are forces there. And then so is that, right? That's a force. So go ahead and relax. So that sometimes, gets overlooked in classical PT.
Yeah.
Now, like I said before, you're not wearing the device and we're just using the volleyball, but the idea is for the folks to understand the value of the CoreX therapy approach is that it's so much more inclusive.
Yeah.
So we're talking about functional range of motion being tied to the core, and then also let's do quick rhythmic stabilization.
Gotcha.
So face me a bit and come into neutral. So this is also classic. So believe it or not, this is knee therapy. So if I oscillate him to the side and try to rotate him, he has to keep his knees aligned in neutral, right? He can't just let his knees go anywhere. Now that's an example of I'm applying force to the upper body, but it's being transmitted through the outer units, primarily the slings, across the body, and then his knee has to figure out how to stay neutral.
Yep.
Right? Okay, and then relax. So the knee has an anchor job, it has a stabilizing job, and it has a responsive job, right? So let's just backtrack quickly. Classical rehab, pain, active range of motion, strength. And
Passive.
primarily in the sagittal plane.
Yeah.
Okay. CoreX system therapy approach. Understanding all of the jobs of the knees. Let's see, knees, even though it's one knee. Accepting loads through ground force reaction, right? Pillar power, strength power, receiving and transmitting information from the ankle, from the ground, through the knee to the hip, and then even across the hip. The knees working together in pairs instead of therapied individually. Understanding them with a mobility and a stability component.
Yeah.
Understanding that there's this functional range of motion that's tied to the core, right? Core power. I don't mean crunches. We've never said that, right? And then having it also the knees accept and deal with loads from the upper body through the outer unit or those functional slings, right, down into the knees for ground force reaction.
Yeah.
Now, this is going to be a pretty bold statement, but that whole list that we just said, all of those ingredients are in every single drill.
Yeah. That's crazy.
In one drill, all of that is occurring, right?
Wow.
So there isn't a list of things like you take the knee and you cut it up into 15 exercises that are all done individually, right? This is each one drill, one movement that the body makes is going to include all of that.
Wow.
Right?
Because our body is doing that in our everyday life. It has to accept those loads. It has to deal with shearing forces. And then if you're an athlete, especially a football player, if you're getting hit, now you have to be able to stabilize so you don't have any, so that injury, that hit you took won't be debilitating and now you're tearing tendons.
Right.
Yeah,
So the biggest point we're trying to make about our program is how inclusive all of the components that the knee does, understands, knows, well, all the things the knee is responsible for, each one drill that the patient does is going to address all of that. It's going to teach neutrality. It's going to teach responsiveness. It's going to teach transmission, right? So in each therapy program, there could be 4 or 5, sometimes 6 different drills.
Yeah.
So that's 6 different opportunities for the patient to have this universal experience of therapy.
Yeah. That makes that's super helpful,
Right?
especially to the masses. Because I was also thinking about you could do this anywhere in the world, just having that as a convenience. Go on vacation with the family, take coexistence with you.
Right.
So that's something that now that I just thought about it again, I was like, wow, like literally we could do this every day, and then it ties into that psychosocial component where they feel comfortable and they feel excited to do it.
Right.
Then that's how you have them habituate that.
Right. Yeah. And also, I have to admit that the workouts are fun.
Yeah, they are.
And challenging in their own way, and they're also follow along.
Yeah.
Right? So there's nothing to read from a piece of paper. There's nothing, you don't have to remember anything.
Yeah.
You just follow along the video, and you know, if you have trouble with a part, you just rewind it and just watch it again and again until you start to feel like, you know, it's starting to make sense to you. So great. I really hope that this 2-video series explanation of the quark system therapy approach is helpful. I hope you'll contact us and ask us lots of questions. Honestly, we'd love to come, if you're local, we'll come do a demo.
Yeah.
Right? Show you how it works with you and your team, or even with a patient or an athlete. Because like honestly, like seeing it and feeling it and doing it, like
you can't describe it. It's when doing it, seeing it on video is one thing and it's fun to do, but in person, it's a whole nother level because it's challenging. But if you apply yourself, you can get it just like that.
Yeah. So thank you so much, Dr. Dean.
Vinzel.
And thank you so much,